Dr. Arun sir and all the physicians to this forum. We'll start this meeting with this physician's prayer. So, dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray, give skills to my hands and clear vision to my mind, kindness and sympathy to my heart, give singleness of purpose and strength to lift at least a part of the burden of my suffering fellow man, and a true realization of the privilege that is mine. Take from my heart all guilt and worthiness, that with the simple faith of a child I'll rely on thee. So, and I welcome you all. So now I hand over to Professor Dr. Sheshatri sir to give a short introduction.
Good evening, everyone, dear friends. It is indeed a pleasure to chair this 44th continuing medical education program of Vellore District API. Vellore District API has been continuing its efforts to educate the members through these programs on varied topics by different medical specialists from different parts of the country. And it has been well attended, and at the end of each session, we have had very interesting discussions, and all the members have benefited greatly from these efforts, even during pandemic times. I welcome you all to this interesting evening with Dr. Arun from Apollo Hospital, a pediatrician who's actually taken over gastroenterology as a specialty, who will enlighten us about current concepts in pancreatitis and will dispel the myths surrounding this acute medical problem. Thank you.
So, thank you, sir. On behalf of API Vellore branch, it's my great pleasure to welcome our distinguished guest speaker, Dr. Arun sir, who is a consultant medical gastroenterologist working at present at Apollo Hospital, Greams Road, Chennai. He's a member of so many associations. His area of interest is the plasmapheresis in acute and chronic liver failure and liver transplantation and various guidelines. So now I'm handing over to Dr. Arun sir to proceed this CME.
Just a minute, madam. I will just share my screen.
Yeah, sure, sir.
Thank you, Team API, and I would like to thank Professor Sheshatri sir and also Dr. Anita for being involved in this session for a long time. We've been discussing about that, and it's really a great pleasure for me to join along with you in this wonderful Sunday to share some insight about the basic thing what we are supposed to remember when we are going to manage a patient with severe acute pancreatitis. Because in our clinical scenario, most of the time we will be getting frequently, even as a physician, as a surgeon, as a gastroenterologist, we'll be encountering this problem frequently. When you're going to manage a patient with severe acute pancreatitis, what are the basic things you are supposed to recognize? How do you diagnose a patient with pancreatitis? Once a patient being diagnosed as acute pancreatitis, how are you going to step up your management protocol? What are the various guidelines being ensured to brush up the knowledge? I'm here to discuss something about that. So as you all know that, can you able to hear my voice well, madam?
Yes, sir, it's clear.
Can you able to hear, sir?
Voice is very clear.
Clear, sir.
Yeah. So to discuss about this pancreatitis, as we all know, any inflammatory condition which is going to involve, and it could be acute pancreatitis or any chronic pancreatitis, or it could be a recurrent acute pancreatitis. What do you mean by the terminology? What is called as acute pancreatitis? If it is going to last in the early phase, acute onset of presentation, and if you're going to document elevation of your amylase and lipase more than threefold, and imaging evidence if it is going to be without much of evidence of calcification, without much of evidence of pancreatic duct dilatation, that shows very clearly this patient is going to land up with acute pancreatitis. But once the patient is going for chronic pancreatitis, that shows evidence of calcification in the background of malabsorptive state, in the background of pancreatic duct dilatation can be there. And intervening period, there might be another thing, what is called as recurrent acute pancreatitis. In a period of time, you are going to get the same episode of acute pancreatitis without any worsening of symptoms. That is what is called as recurrent acute pancreatitis. So always when you're going to brush up this knowledge, we should remember the clinical presentation in acute pancreatitis. Most of the time, the pain is starting in nature, the pain predominantly in the epigastric region. The pain is going to radiate to your back, and once a patient is going to land up with moderate to severe severity, there is high possibility for this patient to land up with worsening of events, with organ failure, and all those things we are going to brush up right now in my upcoming slides. So acute pancreatitis and chronic pancreatitis. What is this acute pancreatitis? It could be because of edematous interstitial pancreatitis, which is going to last around 80 to 90%, and necrotizing pancreatitis, that might be around 20% of the population can land up with that. So severe acute pancreatitis.
So sorry for the interruptions. Are you moving the slides?
Now, next slide I'll change, madam.
Okay.
Can you please see my next slide?
No, sir, that's why.
We are still in the first slide. The management of severe acute
Now
pancreatitis.
I'm now I'm the second slide. Can you please see my second slide?
No, sir, it's not moving.
Sir, you have to select the second slide from the slide bar on the left side.
You just click on the second slide, sir.
So I think
now you are on the third slide. Yes.
Now in the third slide.
Now you're on the third slide.
I think I can present in this mode rather than going for the PPT mode.
Yeah,
yes, no problem, sir.
Okay. So now you can able to see the slides, no, sir? Yeah.
Yes, sir.
So basically about severe acute pancreatitis is nothing but a medical emergency. What you're going to look by 2015 global burden. So more than 1 lakh population have been reported because of that, and 8.9 million cases in the world with 1,30,000 deaths have been reported. And usually, and in Indian scenario, alcohol is going to consider as a common etiology. But if you're going to look into various papers from CMC Vellore and PG Chandigarh, what have been quoted, that gallstone pancreatitis is still more higher, around 30 to 40%. See, there are various etiological focus for acute pancreatitis. One because of gallstones, one because of alcohol, and various other drug induced, or it could be because of toxins. So many etiological, it could be because of idiopathic nature also. There are so many etiological factors to consider for acute pancreatitis. That's not the main area for us to discuss. Once the patient is going to check out with the evidence of pancreatitis, how are you going to diagnose, how are you going to run, and before brushing into that area, we need to know something about the basic pathophysiological aspects of what is going to happen once the patient is going to land up with pancreatitis. This is what the normal enzymatic action, because if you know is the exocrine as well as endocrine function is going to happen in pancreas. So there are multiple enzymatic responses going to, because the response element, the main function zymogen activation cells is going to get located, as zymogen granules is going to be located, and followed by, once the patient is going to release from this trypsinogen to trypsin. So we need to have a multiple formation. Once the enzyme is going to get released into duodenal lumen by formation of chymotrypsin, elastase, and phospholipase and carboxypeptidase, thereby which is going to have a normal enzymatic activation is going to be done. But there's premature activation in case if it is going to happen, and followed by if the chymotrypsinogen, proelastase, all those things are going to get exceed, there might be trypsinogen inhibitor pathway which is going to get activated. That is the area where you're going to land up with pancreatitis. So there are so much of protectives are there. One is by compartmentalization. This thing means compartmentalization is nothing but your digestive enzymes are contained within the zymogen granules and acinar cells. Your remote activation, your digestive enzymes predominantly will be secreted as an inactive proenzymes within your pancreas. Your protease inhibitors, that trypsin inhibitor, is secreted along the proenzymes to suppress any premature enzyme activation. So once a patient is going to land up with evidence of premature enzyme activation, that shows evidence that the patient is going to land up with worsening of events. It could be because of ARDS, it could be because of organ dysfunction, multiple other complications. So premature enzyme activation is the one thing we are not supposed to forget. And next to that, your auto shut off with the trypsin destroys trypsin in high concentration. So that's the main reason. Now, some protective measures are still going on in order to protect your pancreas from these various pathophysiological aspects to take on. Once a patient is going to have this acinar cell injury by your various toxins, for example, your gallstone, your alcohol, your toxin, all of the drug induced, once the patient is going to have to get activated, once the protective mechanisms, if it is going to get failed, like your compartmentalization and remote activation, all those things, if it is going to get failed, that's the area where you're going to land up with pancreatitis. So once the pancreatitis, because of premature enzyme activation, you are going to have auto digestion of your own pancreatic tissue. that will predispose to multi-organ involvement by your vascular insufficiency, your WBC activation, and multiple enzymes is going to take on into your circulation, followed by you're going to land up with various complications and organ failure. This is the basic slide right from a physiology. You should remember that the various enzymes, what is going to happen, why the pancreatitis is going to land up with multi-organ dysfunction. You should remember that because of trypsinogen to trypsin, which is going to get converted, followed by the activation of various pathways. Mainly, we should remember that prekallikrein agents, phospholipase, and your hypercalcemia mainly by lipase activation, your various coagulation cascade by thrombosis and the other organ system inflammation is going to set by age-1 factor, your kinase system activation, that's all is going to get activated. And once the elastase is going to get involved, that shows evidence of capillary leak, that shows evidence of hemorrhage and shock for this kind of patients to land up. So it is going to predispose to multi-organ injury. The stage 1 is mainly by pancreatic injury, and stage 2 by local effect. Which is predisposed to retroperitoneal edema and stage shock and metabolic disturbances and sepsis and organ failure. So this is the area, the pancreatic injury to systemic complications you are going to land on. So how are you going to grade your severity? So mild to moderate to severe. So as per revised Atlanta criteria from 2013, we'll be looking into account. So remember simple things. I don't want to make things very, very complicated, because pancreatitis is one important area which we're not supposed to forget when you're going to manage a patient with severe upper abdominal pain. So mild acute pancreatitis, there won't be having any organ failure, BP, vitals, all those things will be stable. And always remember, assessing the clinical status, look for organ failures, basic X-ray. Everything should be muted, please. There might not be any evidence of organ failure. There might not be any evidence of any systemic complications or any local complications. Once the patient is going for moderate severity, which means the organ failure will slightly be there, will be resolved within a period of 48 hours. There should be evidence of transient failure, but local and systemic complications may be there. So local complications like your peripancreatic fluid collections and all those things can be there. Once a patient is going to land up with severe pancreatitis, the organ failure, which is going to persist even after 48 hours, and there might be multi-organ dysfunction is going to take on. So the early phase and the late phase, the early phase usually because of your cytokine storm, which is predisposing to a systemic inflammatory response, and the late phase, the systemic inflammatory response, if it is going to be persist for a longer duration, there the late phase is going to take on. This is what I've been discussed with you all, the revised Atlanta scoring, what have been mentioned rather than the previous 1993 revised criteria shows that organ failure, if it is going to be last for more than 48 hours, it shows evidence of severe acute pancreatitis. So once the patient is going to land up with severe acute pancreatitis, that's the area we need to refer the patient to IS center. That is the most important thing, because mild to moderate in a secondary level centers we can manage. But once the patient is going to land up with high level organ dysfunction, as what you are going to assess by a Marshall scoring, this is nothing but a modified Marshall scoring being developed recently based upon your respiratory, renal parameters, your hepatic parameters, your cardiovascular and hematological and neurological parameters. What you are going to take into account once these parameters is going to take on, as the patient is going to respiratory insufficiency, the ARDS criteria, your renal insufficiency is going to take on, that shows evidence that the patient is going to have worsening of your organ dysfunction. That shows once the patient is going to land up with high Marshall scoring, that shows the evidence of mortality is going to touch more than 70 to 80% in the background of pancreatitis. So as we all know that the basic pathophysiology, etiological focus mainly by alcohol as well as biliary, sometimes even trauma, and always you are not supposed to forget that ERCP-induced pancreatitis as per your Cotton's criteria. There are so many things are there. 5% of the population pancreatitis is going to develop. There are possibility because of post-ERCP related. You should not forget that. And AIDS related and vasculitis related is still uncommon even for that. But even then, there are high possibility for us to consider when you're going to manage a patient with pancreatitis. So this is what the basic CT imaging, what you're going to look for evidence of pancreatic necrosis, and CT scan imaging of pancreatic necrosis and acute fluid collection, what you're going to see. So this is what, and you should not forget this basic mnemonic. So any patient who is going to present to us with evidence of pancreatitis, It is going to this basic surgical terminology, which has been taken from multiple surgical books, what they've been given in that. So it's going to drink you like a fish, it's going to burrow like rodent, and it's going to sting you like scorpion, it's going to kill you like leopard, and it's going to eat you like wolf. So pancreatic necrosis, your dehydration, your fistulizing process, your severe pain, and life-threatening event, it's going to set on once the patient is going to take on with evidence of acute pancreatitis. So always you should remember, any insult by your various triggers and etiology will be predisposing to your tissue injury, followed by your systemic inflammatory response, nothing but based upon your total count, based upon your fever, leukocytosis, all those things, if you're based upon SARS criteria, and followed by the patient is going for either multi-organ dysfunction, either the patient is going to recover or the patient is going to die. So that's how it's going to take on. Basic definition for SARS, your temperature, your heart rate, your WBC count, your respiratory pattern, as well as your PCO2 to be taken into consideration, and 2 or more criteria, if it is going to get fulfilled, that shows evidence that the patient is going to have SARS. And always you should remember that the pancreatic microcirculation is going to be well established, because you all remember that the hepatic circulation, all those things, but pancreatic microcirculation, the interest in that area is being growing very high. Once a pancreatic microcirculation, if it is going to get disrupted, there might be evidence of vascular endothelial growth factor receptor activation. Once this patient is going to take on, that shows land up with capillary leak, that shows evidence of going to land up with short multi-organ dysfunction.
Sorry for the interruption. Your video is in between, it's freezing.
To be large, if it is, and if it is going to be persist for a longer duration of time, which means whether the patient needs drainage or not. For that, various papers being tried. Always in basic possibility, always conservative management we can consider. But once a patient is going to have worsening of events, a large pseudosis, which is being persisting for almost 3 to 4 weeks, then at that point of time, we can go for a catheter-based, a percutaneous drainage. All those procedures can be considered. But always we should remember, whoever the best possibility, we need to try a conservative line of management. Most of the time, it will be recovering on its own. No intervention on 30 to 40% of the population is needed. But once you're going to do a intervention, once you're going to do a catheter-based drainage to this kind of patients, there might be evidence of worsening of infections, even for the patient who developed a catheter-based drainage, rather than you're going to manage a patient with infection. So always wait, watch, assess, monitor. If worsens, go for catheter-based drainage. But look for evidence of necrotizing pancreatitis. The clinical scenario is like that. Fever is going to persist beyond 1 week. Your total leukocyte count is going to get increased. So that shows evidence of suspected evidence of your acute necrotic collections in pancreas. So whether to drain as per your Indian Academy of Pancreatic Society guideline. So the percutaneous or endoscopic drainage or necrosectomy, where possible, you can try to delay, but there are some possibility we need to wait for walled off to get the collections to get walled off, so we can try to delay up to around 4 weeks rather than intervening in the earlier phase. But even then, there are some papers to demonstrate that the infected pancreatic necrosis, you need to intervene as early as possible. So we can consider, if the patient status is not improving, the infected necrosis, if it is going to be more than 30%, if the patient clinical status is not going to get improved, then we can consider the earlier phase to prevent the worsening of events. And for this, either by drainage procedures or necrosectomy or video-assisted retroperitoneal drainage or percutaneous drainage, there are so many drainage procedures or endoscopic procedures are there. Either by surgical or endoscopic. One thing I would like to say, when you're going for necrosectomy, now endoscopic necrosectomy, we can place a metallic stent, what is called as lumen opposing metallic stent, we can place, and we can drain that area through US endoscopic ultrasound guidance. So we can do that. But once we are going to consider that, there is possibility for the patient to improve very well rather than going for surgical intervention. Now the endoscopic advent has been made so high, you can consider necrosectomy as per Tenson trial as well as Miser trial. There are 2 trials is there. We are not supposed to forget. It is there in my slide. If time permits, you can have a look on that. So Tenson and Miser trials is tension as well as Miser trials, we are not supposed to forget. In both the trials, there being a huge list of papers being tried in that from 2018 to 2019, either surgical intervention or endoscopic intervention. What they mentioned, endoscopic intervention that shows evidence of good response rather than going for surgical intervention. So infected pancreatic necrosis, you can go for percutaneous drainage. Then we can consider, if it is still persisting, we can go for a percutaneous endoscopic necrosectomy. And there are other complications like your intra-abdominal hypertension, your hemorrhage, your intestinal fistula, your infected ascites, your pancreatic ascites, in which your triglyceride level, once a patient is going to have any trauma in your pancreas, your pancreatic duct disruption, all those complications to be analyzed properly when you're going to manage a patient with acute pancreatitis. Remember simple thing before I'm going to conclude this presentation. So managing a patient with pancreatitis is one of the most crucial things, recognizing the complications, addressing the event, look for the etiological focus. And one more thing I should not forget here, gallstone pancreatitis. Gallstone pancreatitis, you can withdraw, you can do ERCP within a period of 2 to 3 days. Once a patient is going to have evidence of cholangitis, early ERCP mandatory, but you need to do cholecystectomy on the day of, before discharging the patient. But if the patient is having evidence of gallstone pancreatitis, no much of pain, always we can wait and watch. And once the patient's status is improved, we can do a ERCP intervention if it is there. And next to that, if the patient is having severe evidence of infection, another focus in the background of gallstone pancreatitis, if the patient is having severe acute pancreatitis in the background of shock, at that point of juncture, you can consider a gallbladder drainage procedures rather than considering the patient for cholecystectomy in the initial part. So these are all the area you're not supposed to forget when you're going to manage. And one more important thing I would like to discuss, because clinician aspect, as a clinician, as a surgeon, we are not supposed to forget, how are you going to differentiate a gallstone from a alcohol-induced pancreatitis? Because gallstone pancreatitis, when you're going to do a liver function test, most of the time it will be abnormal. The bilirubin will be high, the liver enzymes will be high. That shows evidence of gallstone pancreatitis. But even then, if the patient is having small gallstones in the background of large amount of alcohol, the evidence of worsening of liver function test will not set in at the initial point of juncture, but it happens within 24 to 48 hours in the case of gallstone pancreatitis. So LFT most of the time will take time to worsen in alcohol rather than in gallstone pancreatitis. That is one strong point for us to address, whether it is mainly because of alcohol or whether it is because of this gallstone-related pancreatitis. So before winding up, managing the patient, recognizing the complications, addressing the nutrition, pain management, fluid hydration, tackling the complications. Once a patient is going to develop fluids, once a patient is going to develop necrotic changes, whether the endoscopic intervention or wait and watch or necrosectomy, whatever the modality if you're going to plan of, you need to plan accordingly and need to manage a patient to improve this clinical scenario, to manage pancreatitis in a successful way and to overcome all the complications successfully. With this, I'm happy to rest my presentation and I'm happy to take away questions if anything is there to take on. Thanking you all for patient listening.
Okay, sir. Thanks a lot, sir. Actually, an extremely apologies for this continuous interruption, sir. And for
the first time this kind of things. I don't know what's the reason. But even my slides have not been uploaded properly. Usually it won't happen, but this is the first time. That's why we will usually go for even before this meeting. We will go for a
happen. Actually, so many meetings we conducted, sir. Actually, this is the first time we are facing this kind of disturbances. So one question in the chat box, sir, from Dr. Satish Kumar, sir. I will read that question, sir. If an alcoholic patient with the gallstone present on the 3 to 4th day, how to know which is the cause?
I told you just now,
Yes,
so if you're alcoholic with a gallstone, if it is going to present on 3 to 4 days, always we need to see the baseline LFT values. In the background of gallstone-related pancreatitis, the LFT value will be slightly worse and the enzymatic elevation will be slightly high as alcoholic pancreatitis, because alcohol is always a diagnosis of exclusion. We should not consider alcohol as a first possible etiology whenever you're going to suspect a patient with gallstones. Do the basic liver function test, look for the evidence of worsening of pain, look for the evidence of biliary pathology, look for the evidence of biliary colic pain is there or not. Along with that, the liver function test is there to help you to aid in the diagnosis of acute pancreatitis is there or
Okay. Is there any question? You can unmute, I can ask. So now which day we can go for the radiological investigation? So for acute pancreatitis, most of the time they'll tell day 2 or day 3, something like that.
See, always you should remember the radiological investigation. The first and foremost, if you are suspecting a pancreatitis, you need to do a X-ray abdomen as well as your X-ray chest. That's the foremost important thing you're not supposed to forget on day 1. Okay. X-ray abdomen and chest posture is most important to do on day 1. CT abdomen, once a patient is going to develop any complications, if you are suspecting worsening of events, on 48 to 72 hours, we can do. MRCP most of the time is not recommended for a patient, but when you're thinking about evidence of CBD prominence, when you're thinking about evidence of gallstone which is being penetrating into your bile duct, when you're thinking about evidence of cholangitis worsening of events, that shows evidence for your MRCP to take on within around 48 to 70 hours. But the initial period, usually ultrasound is more than enough suffice. Within 25 to 48 hours, if you're suspecting any worsening of complication, then at that point of juncture, you can go for CT abdomen, which is mainly based upon your contrast study. Also, you can think in terms of pancreatic protocol regimens.
Yes, sir. So, and one more question from Dr. Parni, ma'am. Guide us regarding the management of exocrine deficiency.
Exocrine insufficiency is most complex scenario. You should not forget that. But once a patient is going to land up with exocrine insufficiency, that shows evidence that the patient is going for evidence of chronic pancreatitis. Okay. So once a patient is going for evidence of chronic pancreatitis, because almost your duct, ductal disruption, your pancreatic gland disruption is going to happen, more than 80 to 90% of the population is going to come down, followed by, that shows evidence your chronic pancreatitis is going to get activated. And once the patient is going to be landed with evidence of chronic pancreatitis, the nutrition status, your steatorrhea, based upon your clinical parameters, your various pancreatic function test assessment, there's so much of a huge list of tests, but very cumbersome, very difficult to do in Indian scenario. Some invasive and non-invasive procedures there. Once you're going to consider all those things you can do, but you need to think in terms of pancreatic enzyme replacement therapy to be addressed very strongly, whether 25,000 units or 10,000 units, whatever the things you're going to consider, you need to give a mini sphere coated encapsulated molecules. We are going to think the only problem where the long-standing evidence of fibrotic changes may be the evidence of structural changes may be based upon your pancreatic enzyme replacement therapy and serial monitoring for this kind of patients to land up with evidence of pancreatic malignant changeovers. And you need to think in terms of your mutational analysis, like a SPINK, CFTR, all those things, the trypsinogen mutation, all those things to be studied when you're going to think in terms of pancreatic, chronic pancreatitis. The one problem is enzyme replacement is very costly approach. And if the patient doesn't deserve the enzyme replacement therapy, if the clinical status is still worsening, the steatorrhea, if it is going to be more than 7% of the fat, if it is going to get excreted, at that point of juncture, that the patient is going to go for a surgical intervention may be needed at that point of juncture when you're going to manage a patient with chronic pancreatitis.
Thank you, sir. And next is, what is the cost of ulinastatin course, sir? Total ulinastatin course.
It's not a strong addressing molecule, but in Indian scenario, most of the doctors have been using that in most hospitals. But when I'm practicing, in my experience, I've been trying to a few patients, but usually, even if you're going if you're not going to manage, even with your ulinastatin, the most of the scenario is going to get improved. Addressing the patient promptly within first 40 to 70 hours in early intensive regimen, if you're going to manage promptly, most of the time the severe acute pancreatitis will come down. But ulinastatin is very costly affair, and the 3 to 5 days course, if you're going to consider now 2 lakhs units being available, you need to give the OD dose or BD dose if you're going to consider, but the cost will be going around 30 to 40,000, I mean minimum 50,000 of oral package will be there. So it will be a costly affair for most of the patients to tackle. So always, is it recommended or not? You need to think, you need to wait, you need to address thoroughly. You should not jump into the conclusion ulinastatin to be considered, because no papers having strong beneficial role for ulinastatin when you're going to manage a patient with severe acute pancreatitis.
Okay. And one more question, sir. Your comment on post-COVID presenting with the new onset pancreatitis, can it happen even after 3 months?
Possibility, new onset of pancreatitis, but how to diagnose that scenario is one complex scenario. No? See, any inflammatory cascade can happen even if that should be evidence of recurrent acute pancreatitis, or it might be evidence of acute pancreatitis. Even post-COVID can present like that once the inflammatory cascade, but how far you're going to see that kind of scenario, how far you're going to establish. But post-COVID pancreatic injury is very, very common in the initial phase, that what we are experiencing in the second wave, when you're going to see acute pancreatitis even being most of the time, but once the patient is going for ICU setup, We are not very sure it's only because of post-COVID or alcohol or coexisting other pathology or it is a drug-induced. There are so many etiological factors to be addressed. If you want to talk about this area promptly, you need more and more papers to refer on for you to address this area strongly.
Yes, sir. Thank you, sir. And one more, sir, from Dr. Manoj Kumar, sir. How long should the pancreatic supplements given to chronic pancreatitis patients, sir?
There is no strong consensus guidelines for chronic pancreatitis patient to manage with pancreatic enzyme replacement therapy. Until the patient survives, you need to go on with the pancreatic enzyme replacement therapy, provided if the cause is going on well, but you need to analyze whether the PERT is functioning or not, whether the patient nutrition is improving, dieting, lifestyle modification, assessing the state of crate, and measuring the fat emulsification. All those things to be analyzed when you're going to manage a patient with chronic pancreatitis. Lifelong therapy sometimes can be considered, but most of the time, no strong papers to recommend that. How long you're going to consider, it's still a questionable issue when you're going to manage a patient with chronic pancreatitis.
Okay, so one more question. What's the cause of the recurrent pancreatitis in children?
Cause of recurrent pancreatitis, always you need to look for evidence of divisum. So most of the time, the pancreatitis recurrent will be idiopathic. But once the patient is going to have any evidence of anatomic abnormalities, like pancreatic divisum, in which your pancreatic duct, if it is going to be placed rather than your major duct and minor duct, it is going to get interrupted. So that shows evidence of pancreatic divisum is going to be there. And other changes like your annular pancreas also can, one of the various congenital anomaly can be addressed. But these things and all, it's always a long-standing pathology. Most of the time, the pancreatic divisum and these things will be there. And at that point of juncture, you can try the patient for a minor papilla sphincterotomy. That definitely going to improve this clinical scenario. But pancreatic divisum, always you should remember that even if it is there, you need to look for other possibilities like your mutation abnormalities, like your genetic abnormalities like SPINK, trypsinogen mutations, and CFTR, all those things to be analyzed. So pediatric pancreatitis is entirely different regimen you're going to manage in this scenario.
Okay, thank you, sir. Is there any more question? I think it's over.
I'm extremely sorry for the things what has happened today. Probably
actually, I should ask for that. Sorry, sir. So we can.
Everything has to go on well. So
yes.
we'll meet you at the next good meet, I think.
Yes, so we can come to the conclusion for the vote of thanks. So I take this golden opportunity to thank each and everyone for this patient attending this meeting. On behalf of APA Vellore Branch Office Bearers, I extend my gratitude to our distinguished guest speaker, Dr. Arun sir, and also we apologize for this unexpected interruption. So many interruptions since the starting of the meet. In spite of that, you are patiently cooperated well with us, and he gave an excellent talk even without the slides and brushed up new drugs that Olina sat on and explained very well in each and every aspect, and patient answering for all the questions, sir. Thank you so much. And thank you everyone for their patient attending this meeting. So thank you, sir. Definitely we'll call you on the next meeting in a physical meet, sir, to Vellore. So always you're most welcome, sir.
That's what I'm expecting to. And thank you all. Thank you, team APA Vellore. And it's really a great pleasure for me to be here in this session to join the basic knowledge and sharing on this acute pancreatic management protocol. Thank you very much, team.
Yeah, thank you, sir. Soon we'll invite, sir. Thank you so much, sir. And I'll tell thanks to Shilpa ma'am. She only talked about you, sir. He's very interested to give a CME. I just came to my mind your name, so that is why I just invited, sir. So thank you so much.
Thank you.
Thank you.
Thank you very much, Seshadri, sir. And thank you, team API, to give me an opportunity. Thank you all. Thank you very much.
Seshadri, sir. There. Satisha, you want to talk? Seshadri, sir?
No, ma'am. It was an excellent talk. Dr. Arun was patient enough to come back, and with all the hurdles, he still continued talking, even without the slides. That was great.
Okay, sir. Shall we end, sir?
Thank you.
Okay, thank you, sir. Thank you.
Shall we wind up, ma'am?
Yes, sir. Yes, sir. Thank you, sir.